Hello and welcome to our clinic's webinar on lymphedema. Don't forget to submit your question during the presentation in the question and answer tab. We will get through them at the end. I'm Caroline and I work as a surgery coordinator. I am the one that will help you with all the practical things regarding your surgery. And now I hand over to Anders.
Hello everyone, my name is Anders Liss. I work as a surgeon here at our clinic in Uppsala. And I've been treating patients with lymphedema since 1997. And that's the year when I started to collaborate with Professor Håkan Brorson, who's then working in Malmö. And now let me introduce to you Professor Håkan Brorson, who will take over from here. Please, Håkan.
Thank you for the invitation to talk about lymphedema. I also work here in Uppsala at Art Clinic, and we will have about 45 minutes and then questions and answers. So I'm professor of plastic surgery at Lund University, also in Buenos Aires and in Sydney. So here is my thesis from 1998 about liposuction of arm lymphedema. And here's another thesis by my PhD student, Matthias Hoffner, in 2018. Also about liposuction and treatment strategy, pathophysiology, and long-term outcomes. And the last thesis is by Tobias Karlsson about liposuction of arm and leg lymphedema regarding tissue composition and treatment outcomes. So what is a lymphedema? Well, when the blood circulates through the vessels to the arteries, and then it goes over to the veins. And at this step, like here, you see the yellow lymphatics. The small capillaries leak out about 5 to 7 liters of fluid in the space between the muscle fascia and the skin, and where the adipose tissue is. And here you can see actually a lymphatic vessel from the mouse. And you can also see the valves that propagates the lymph centrally in the body, like this. And here is a schematic, a small animation of how it looks like when you look under the skin. So here you see the lymphatics, which are also in the skin, but also below the skin. And that transports all the lymph to the lymph nodes, and these vessels starts blindly and has small openings that can drain the lymph from the space in the adipose tissue. And these vessels also have muscle cells that contracts the lymphatics in order to pump it back to the blood system, and also remove proteins that should not stay in the intestines. Way back 30, 40 years, for example, after breast cancer, the irradiation sometimes was too much, and in this case, the patient had a severe lymphedema, and the arm had to be amputated. So here is one of the first patients we operated on, 4.2 liters excess volume, and another patient here, 3.1 liters. And here are some patients that we will discuss during this presentation, how we can normalize the volume of the arm and leg. Stemmer sign is a very precise sign. So if you cannot lift up the skin like this on the right picture in a thin fold, you know that you have a lymphedema. Some patients with lymphedema has a negative sign, but 99% have a positive sign. Hitting test is the cheapest test in the hospital, so you press as hard as possible with your thumb for about 2 to 3 minutes, and then you estimate the depth of the pit. So this patient is not for surgery, this is for conservative treatment by bandaging and removing the fluid. This patient here has minimal pitting and could be a case for liposuction. So here are a patient with 3.1 liter, and this is 1 year after. There is no need to excise any skin. And we did an MRI on one of the first patients, and here you can see the abundance of adipose tissue And this is as compared to the normal arm. And here are actually a picture of two slices, one slice from the normal arm to the left and the lymphodematous arm. You can see the excess adipose tissue and also that some of the muscles are turned into adipose tissue. This is what we normally get out. So to the left, you have 2 liters of just adipose tissue. So about 90 to 100% is fat, what we take out. When I talked about this, the meeting of the International Society of Lymphology in 1997, nobody believed in this. They thought I had manipulated my slides. And some surgeon said that I've never seen this. Is it something peculiar for Swedes? Or that maybe Swedes eat different food than around the Mediterranean? And liposuction for lymphedema is science fiction. Now it's no longer science fiction, and we will get into this. So one question was that, is there evidence for adipose tissue hypertrophy in lymphedema? So we had to analyze this. So we used the volume rendered computer tomography in 11 patients. So you can tell the computer just show the density pixels that have the same density as adipose tissue. And you can subtract the pixels. And in this case, we have an excess fat volume of 1.3 liters. And also here, almost the same, 1.3 liters using volume rendered computer tomography. So in these 11 patients, they had 81% more fat in the lymphodematous arm. Then we continued with another technique to estimate adipose tissue, but not only adipose tissue, but also muscle tissue and bone. And here you can see the fat volume to the left here. This is before surgery, and you can see that it's actually on the minus. So the arm or leg is somewhat smaller than the normal one. But also muscle volume increases in lymphedema due to the heaviness of the arm or leg. So it's like you are training, going to the gym and just lift weights on one arm, you get more muscles. And also after 1 year follow-up, the muscle volume decreases, but not to a normal level. So I came across this paper by Schneider and colleagues in Nature Genetics in 2005. And they had the model where, we can talk about this a little later. So it's actually inflammation upregulated genes that leads to excess fat deposition. And the goal as a plastic surgeon is to remove the excess fat in order to get complete reduction with the help of liposuction. So here we're coming back again. We have the pitting. It's too much, so we know it's fluid. And that's why we should not operate the patient. This is a patient that needs conservative treatment by physiotherapist or occupational therapist. And here we have no pitting, and then we can carry on with liposuction if the patient wants to proceed. So untreated lymphedema has about 50% fat and excess fat and excess fluid, so 50-50. And then you do the bandaging, conservative treatment in order to get rid as much as fluid as possible. So you have a non-pitting edema, and then you do the liposuction in order to get a complete reduction. So here again, before and after. And follow this, we have this controlled compression therapy when we take measurements on the healthy arm 2 weeks before surgery. So we use the normal arm or leg as a template to put on the arm or leg at the time of surgery, because we want this size. And afterwards, we gradually take in the garment by the team or by the patient herself, by renewing the garments or even using a sewing machine. And we have frequent renewal of garments, and we have frequent checkups postoperatively in order to see that the patient gets the amount of garments that needed, because this is very individual. For example, when you have diabetes, you might need 3 bottles of insulin per half year or per 3 months. And this is the same for lymphedema. Some patients need 2 garments every 6 months. Some patients with a heavy work need 2 garments every month. So That's why we have to see them and individualize the compression. So we don't use bandaging because the patients are already treated conservatively, and we do not use manual lymphatic drainage, and we don't use the pumps. So we have postoperative compression, custom-made flat-knitted class 2 to 3 garments, and in Sweden, patients do not pay for the garments. So for arms, we have compression class 2, and for legs, we have 2 layers, class 3 and 2 on top of each other. So a few results here, 2.6 liters 1 year later, 4.2 liters 1 month after, 3 months after, and at 1 year, we have a complete reduction. We measure volumes using water plethysmography. You can also use conferences and use a computer program which is based on the formula of the truncated cone. So we weigh the water, and then we know the volume of the arm, and we measure both arms and subtract, and then in this series of patients, we have 1.6 liters excess volume. And the follow-up you can see here, so we have actually seen 8 patients at 25 years after surgery. So here comes the results. So you can see that between 3 and 6 months, we have a complete reduction that stays there during the follow-up period of 25 years. So here is how it looks like. We use a tourniquet to stop the blood flow in the arm because we don't want any bleeding. And as you can see here, after removing the tourniquet, you have this reactive hyperemia, and we put the garment on after that. Here's a short video how it looks like in the arm. So we exsanguinate the arm using a rubber band, and then we have this power-assisted liposuction machine that facilitates the removal of fat, especially also in the legs, where sometimes it's quite fibrotic in the distal part of the lower leg. So we go from distal to proximal, and we have taken specimens for analysis of the adipose tissue as well. And you remove as much possible. And you can see the vibrating cannula that really is very good and speeds up the procedure. So going up to the tourniquet here, and here's very little blood in that. And then I changed to a little thicker cannula, 4 millimeter. And now the arm has been, the fat has been removed from the arm, but now we need to treat the area under the tourniquet. In this case, we have used one of the patient's old garments that we had taken in using a sewing machine, but nowadays we don't do this anymore. So we have always a clean garment that we put on at the time of surgery that has been measured according to the normal arm. And we put some handpiece on and also remove the tips here of the glove so the patient can use the hand afterwards. So then we remove the tourniquet and the blood starts to flow in the arm again. And then the proximal part of the arm, we use a tumescent method where you infuse 1 liter of saline with adrenaline. And here is a 4 millimeter cannula going all the way up to the armpit. And you can see how easily the skin contracts. So there's no need to use exercise in the skin. This is 2 days after surgery. And you can see that the arm are almost equal in size. So compression is very important, and you have to individualize it. It's not like you give 1 garment a year or 2 garments a year. That doesn't work. And you should, in the beginning, before the arm has the same size as the normal one, you have this band to keep it up, not coming down. And it should look like this. And we also, because it was said that, well, when you do the liposuction, you will destroy the lymphatics. But my answer to this was that they have no functioning lymphatics, and that's why they have lymphedema. But it was quite interesting. So we could show that using lymphoscintigrams, we showed that there was no further impairment of the already decreased lymph transport capacity. So actually, there is no need for lymph-sparing liposuction with indocyanine in green, that is a kind of color that you inject in the skin, and you can sometimes see lymph vessels, and that is not needed. And sometimes the patient gets infections like cellulitis or erysipelas, and then you have to treat with antibiotics, of course. But we have shown that when you do liposuction on R, we decrease the incidence with 87% of this infection. And also for legs, we have shown that there is a 65% reduction in the incidence of infection. So how can compression be increased? Well, you take thermal measurements, you use thermal compression class, you have multi-layer as we have on legs, and you increase the number of garments. And here you can see the immediate post-operative period that the measurements are taken quite firm, so you have this kind of indentation in the skin. So don't just put the tape measure around, you have to pull. And we also sometimes take in the garments. And here you can see two examples of patients that have used the sewing machine to take in the garment when they felt that the sleeve was slack, and that can also be done, and it goes quicker. So also when you wash the garment, you can see here that 2 centimeters on one side, that means 4 centimeters all around. So just using the garment for one day or night, 24 hours, the compression garments kind of dilates and gets larger. So that's very important to every morning put on a clean shrunk garment that has been washed the day before. That's why you need 2 garments of each garment. And we send the measurements by web to the manufacturer, and we get them within a week. And you can use these easy slides to make it comfortable to remove, to take on the garment. Do we need manual lymphatic drainage? Well, manual lymphatic drainage has a side effect about having you release these well-being hormones like oxytocin, but it has no effect on volume reduction. There are more than 40 papers showing in randomized studies that the lymph drainage has no effect on volume reduction. And here is one of these papers saying that manual lymphatic drainage adds no further volume reduction to complete decongestive therapy. Sometimes we saw this way back. The patient has been to the therapist and had a good reduction after 1 month, and then comes back after 6 months and it has increased. And then they are out of work a couple of weeks to do the bandaging and maintenance therapy. And then the same thing happens. If the therapist has seen the patient regularly, like every 3 months, then they could have their garments renewed in order to prevent this increase of excess volume. So this is how we do it. Frequent controls the first year to see how many garments a patient needed. This is very individual. So like this, you can see it's going up here. Okay, we have to order new garments. And so we know after 1 year how many garments, and then you can prescribe this number for the whole next year, and then just see the patient once a year. So if an edema increases due to ineffective garment or decreased patient compliance. So the key to success is to inform the patient about how lymphedema works, and also have a mental contract to use the compression garments 24/7. And if you don't have money for compression garments, it's not a very good treatment. I mean, you need the compression, and follow-up is important. So I would say that for actually 8% of our arm patients do not wear any compression. And these patients are those with a BMI around 20 or below. And I think that the remaining lymph transport is able to cope with the need of draining the arm. But for legs, they need to use the compression 24/7. So if they have 2 garments on daytime, they use one of them nighttime. And the next day, they take on 2 shrunk clean garments to put on. So a little about leg lymphedema. And this is what was done in the 60s when they actually removed the fat, the skin down to the muscle fascia and put skin grafts on. And here you can see it's, I mean, this is what was done in those days. It doesn't look nice, but it was relief for the patient. This kind of surgery is actually done in some countries, like in India, where they don't have access or money to pay for compression garments. But sometimes these skin transplants break down and you have infection and oozing from the lymphatics. So we've operated on about 130 patients, 50% primary, 62% secondary, and mostly women. And here we also use volume measurements. So we have this kind of elevator, and the patient puts one leg into the canister and the water flows out. And then we weigh the water, and then we get the volume of the leg. And in this series of patients, we have an excess volume about 3.9 liters. And here are the patients that we follow for 20 years now. And it takes a little longer time, but about 1 to 1.5 years after surgery, we have a complete reduction, but you can also see that it stays there. But also when the muscle volume goes down, also contributes to the excess volume reduction, of course. So here's a short video. This is a lady, 73 years old. She has had lymphedema for 50 years. So actually, since she was 23, also here we have a tourniquet and stop the blood from circulating in the legs to minimize the blood loss. And you can see already on the distal part of the lower leg that we have a good effect of the liposuction. Also here we use this power-assisted liposuction. And here we check the measurements according to the healthy leg. And so we are in par with the normal leg. And it's a good workout. So you do 1 or 2 legs a week. You don't need to go to the gym. And here you can see just a yellow fat, and there is no blood. And here you can see that normally the patient does this by herself, but this is 2 days after liposuction. And you can see there are no hematomas, sagulations, or ecchymosis, because we don't stitch the small incisions, which are left open to drain. And then the patient takes a shower, lubricates the skin, and put on a clean set of new garments. And here we have how it looks in the operating room when we have finished the surgery up to the tourniquet, and how we put on the garment at the time of surgery. And we have taken measurements for this on the healthy leg, and we ordered this 2 weeks before surgery. We have the easy slide, and then we remove the tourniquet, and it takes about 2 hours up to the tourniquet. And then we infuse 2 liters of saline with adrenaline and get some fluid too. And then we carry on with liposuction here. Now we are just infusing fluid. And then now it's time for liposuction on the proximal part of the thigh. Small incisions, about 3 to 4 millimeters. So the procedure up to the tourniquet takes about 2 hours, and in total about 2.5 to 3 hours. And it's important to pull up the garment properly. So this is the same patient as before, about 6 liters, 5.8 liters, and slight overcorrection with a minus 245 milliliters at 6 months. And here is an interesting patient who had a primary lymphedema. You can see on the right leg there is a slight lymphedema, but then there was a cancer of the testicle. Patient was treated with radiotherapy, and it just exploded. And here you can see the results 20 years later. And here, yes. Okay, so 20 years later, he can wear any clothing he wants. So from here to here, there is no surgery performed. Removal of 10 liters of fluid, lymph, by conservative treatment. Then you get into a non-pitting state. Then we know that the remaining excess volume is adipose tissue, and then you remove with liposuction. So here you see the lymphedematous leg in green, and the yellow is the almost normal leg. And the subtraction shows that there is an excess volume about 14 liters. And then a conservative treatment gets it down, but then we kind of have a steady state, nothing happens anymore. You look at the red line there, and we have this look at 1.5 years. And here it's time to do the liposuction. And eventually we have a complete reduction like this. So this plateau phase, when you have no pitting, we know that the remaining excess volume is adipose. Also shows that the patient is compliant with wearing his garments. Now, how do you treat this leg? With microsurgery, liposuction, or conservative treatment? Here you can see to the left, this is before surgery, and 20 liters of fluid has been removed. You get the middle picture, no pitting, and then 4 years later, you have an excess volume of minus 340 milliliters. She is now married and works full time. Another patient, 9.4 liters. Also here, removal of 5 liters of fluid, and then doing the liposuction, and this is result 2 years later. And another patient, 5.8 liters, and 3 years later. And this lady, 4.9 liters, 2 years later, and she can now wear any clothing and boots as she wants. And another patient, 6.6 liters, 2 years later, she can wear any clothing, and this is 10 years after. She has now, after this, got married and has 3 children and works full time. This patient, also from Denmark, 7 liters. They tried liposuction in Copenhagen at the Rigshospital. Nothing happened. 6 months after liposuction, we had a slight overcorrection of 400 milliliters from here to here in 6 months. And so microsurgery versus liposuction. Well, I was invited to this meeting, and in 2012, they wanted to do microsurgery, and she had an excess volume. And I was questioning because there was no pitting and that's no fluid. And I didn't think that microsurgery would work, but anyhow, they did a adipose lymphatic free flap and a lymphovenous anastomosis. And what happened then, 2 years later, you can see that there was an increase of 655 milliliters. And then I was asked if I could do liposuction on this patient. And I did that 2 years later. And she has then 3.8 liters with an increase of the microsurgery of about 655 milliliters. And here I have measured volumes using the tape measure and the formula of the truncated cone. And to the right, you see after liposuction. Before to the left and to the right after liposuction. And we removed 4 liters of tissue. So here is how it looked. So 655 milliliters after microsurgery, there was no effect. Then after liposuction, a steep decrease, and I saw the patient then 3 years after with a complete reduction, as you can see here. And here you can see to the right at 3 years and to the far left how it was before surgery. And posterior pictures like this. This patient from Sydney, I was asked to operate on because the team had been to Malmö several times, and this was one of their larger lymphedemas. She could not climb these 8 steps up to the outpatient clinic, and we removed a lot. And this is before and after. She was a marathon runner, and she said this.
Shot, and I'm here at the top of Sydney Harbour Bridge, 1,390 steps, 3 months.
So she was very happy, And later on, I get an email. She said that what had changed the last 12 months had brought to my life. My leg is continuing to decrease. I'm still running most days and have lost. She spent 6 weeks around the world with her husband, and there was nothing they didn't do. She had returned to work full time, and she had been to more social events in the last 12 months than she has attended in the last 10 years, and even bought some new clothes. So, in conclusion, adipose tissue dominates non-treating lymphedema, and the deposition starts when the lymphedema appears or soon thereafter. So for arms and legs, still, because we follow this patient a long time, there is no recurrence of the lymphedema. And the excess adipose tissue can only be removed by liposuction, but not by any means of treatment, any other means of treatment. So the outcome of conservative therapy and microsurgery is limited to the presence of the newly formed adipose tissue, which we have to remove. Thank you very much for your attention. And now it's time for questions and answers with Anders and myself. And we are just waiting for them coming in. So Caroline, do you have any?
No, not yet.
No questions. So I think the talk was very informative.
I must say, I'm impressed with the speed. I didn't think that you would be able to show all these pictures within less than 30 minutes.
Yeah,
I've
done it before.
You've done it before, yeah, I know.
Are people shy?
Yes, I think so. No question.
We are waiting for the questions. They are kind of should pop up here any minute. So
most likely you have covered the field completely and there is no question more.
Yeah, hopefully, yes.
But there is still an issue on the microsurgery. There is a lot of talk about microsurgery. In the world right now, it seems like liposuction, everyone knows that you can have good results, but you don't cure the patient. You still have to wear the compression garments. You show this presentation from Spain. Have you any other experiences around this?
Well, some of the patients I've operated on have had microvascular procedures, preferably lymph node transfer and intravenous anastomosis without any effect. So I think that due to when the lymphatics are distended, the smooth muscle cells in the lining of the vessels become fibrotic, and then the pumping properties of the vessels are gone, and they are just like eels in rigor mortis. They cannot move, they cannot contract. So I don't believe in that it works. And I think it's also, in outside Sweden, where we have universal healthcare, we tend to go to evidence-based medicine. But in countries where you're paid for what you are doing, for example, in the United States, insurance companies do not cover liposuction for lymphedema because they think it's a kind of aesthetic procedure, but they pay quite a lot for microvascular surgery. And so I was in the panel in the United States, and they asked me, why don't you do microsurgery in Sweden? And I said, we do a lot of microsurgery, but not for lymphedemas. And I said, what would happen in the United States if insurance companies said that we will not pay any money for microsurgery, but we will pay the same amount for liposuction? How many of the surgeons would still do microvascular procedures? And it's like the saga by H.C. Andersen in Denmark. It's for the King's New Clothes. I mean, it was quite evident that treatment goes where the money is. What do you think?
Yeah, I agree. Is there any questions so far?
Yes.
Yes, please.
You have mentioned both primary.
Just a question.
Yes.
Do you have your microphone on?
No, I don't
Okay,
think.
we can.
No, but we will hear.
We can hear.
We
Okay.
repeat the question.
You have mentioned both primary and secondary lymphedema. Is there any difference in result and treatment, etc.?
No, we have looked into that. The lymphedema is the same. There is no difference. I mean, most of these primary lymphedemas, I would say 99% are in the legs. And they usually appear in women, girls, when in the late teens, when they have this growth spurt, and the remaining defective lymphatic system is not able to cope with a new load of fluid that is needed to be removed from the tissue. And there is no difference in how to do liposuction, and there is no difference in the outcome.
And another question is, do you always have to wear compression garments 24/7?
Yes, I think I made that quite clear.
Do you ever need to remove excess skin?
No, that I also talked about, and there is no need for removing any skin. I know there are some surgeons or in the outside Sweden that excise the skin, but I mean, you have seen the pictures here. You saw the lady with 26 liters excess volume. You would think that there would be a lot of excess skin, but there isn't. And I think it has to be with coding in some patients, in some countries, because when you do a procedure, you get paid for what you do. So when you do the excisional procedure, you get more money. At least in these 400 patients we have operated on, we have never excised skin, and I don't think it's necessary.
I'm wondering how surgery for lymphedema would work when you have fibromyalgia.
Well, if you have lymphedema and fibromyalgia, you could do there is no connection between these two diseases. So there will be no problem.
Mm. How long would a typical stay be at the clinic hospital, please?
Well, you can talk about this.
Well, it's when we operate people, we operate on Monday, and people stay at the ward for 3 days. And then patients come back on day 5 for an open clinic meeting where we change the compression garment. I should say that we operate Monday, we change the garments on Wednesday, and then the patient leave for a hotel and come back Friday, and then another visit back to us on Monday. That is on day 7, and then people go home. After that, we have an appointment after 1 month, and we check out what the outcome is. Most times we don't need to change the compression garments. After 3 months, we need to change the compression garments, and 6 months, 9 months, 12 months. And it's very clear that it's crucial that you have these appointments, and that you realize that this is a part of the treatment. Yes, it's a lot of going back and forth, but we need to have this checkup and increase the compression in order to get the good results.
Do you diagnose lymphedema as well, or do you need a diagnosis before coming to you?
Well, usually when you get an email from the patient, they have already been diagnosed with lymphedema at their home clinic in that country where he or she lives. And they send pictures and they take volume measurements. So actually, based on that, we know that the patient has lymphedema. And if there is any doubt if there is a lymphedema or not, you can do, for example, a lymphoscintigraphy that will show that there is a decreased lymph transport in the arm or leg.
What is the success rate of this surgery?
Anders?
Well, it's actually you that you should take credit for this, because it's if you follow the routine and you wear the compression garments 24/7, you have a complete reduction of the volume. Yes, we do not treat the disease, so to speak. We can't cure the lymphatics, but the symptom of the lymphedema is cured.
Yeah, we kind of turned the clock back to when the deposition of fat started, which starts when the lymphedema starts. And by having this good compression, we have not seen during these 25 years that we have any recurrence. And patients that come to us, they have been wearing garments for years or months, and they are kind of, they are used to do it. So actually there is no change. The only change is that the leg or arm are normalized and they continue with the compression. That's a good thing.
Some other question, are there any restriction when it comes to exercise?
Well, patient, even if I say it before surgery, I get this question the day after surgery. And the answer is, if you want to climb Mount Everest the day after surgery, it's fine, as long as you keep the compression on. That means there are no restrictions. You have to feel your body, and of course you are a little sore in the leg or arm, but then you just take one step back. But actually there are no restrictions.
Other question, should I consider it better to operate when the primary lymphedema is smaller, or how long should I wait?
Well, I would say that the first thing is to have a compression garment. And if it's a very small lymphedema, the compression garment could do the trick, and you could stay a good life without the liposuction. This is, however, individual, and but in most cases, there is very small lymphedema shouldn't be treated with lymphedema. You have some crucial figures on this, I guess.
Well, actually, we have a limit. So the lymphedema suspect should be more than 10% larger than the other one. Otherwise, I have no objection to that. I mean, it's up to the patient. It's a patient who decides if he or she wants surgery or not. And we can say that if you have minimal pitting, more than 10%, then we can carry on with the procedure.
Is it in Uppsala that you perform the surgeries? What does it cost?
I should know the cost, of course, but it's anyway. Yes, we do the operations here in Uppsala. Our clinic have clinics in Gothenburg and Jönköping and here in Uppsala. But as of now, Håkan and I, we're working together here in Uppsala, and this is the place where we offer the operation. I should, of course, know the price, but it's this. You have to ask Caroline for. I know it's a lot of money, and it's not only the operation that is kind of costly, because it's you need to go realize that there is a cost to come for the outpatient clinics, but it's a part of this treatment.
I can tell you that it's cheaper than lymphovenous anastomosis in the USA.
You show a picture of one leg or one arm. How often are both legs or both arms affected?
Well, for arms, I have never seen primary lymphedema in the arms. 100% are lymphedema after breast cancer treatment. For legs, I would say about 5% are on both sides, that is bilateral. In that case, we operate one leg at a time. So let's say after 6 months, if we're happy with the outcome, we can do this next procedure on the other leg. And so we actually have 2 patients here in Uppsala that we have operated on, and with a good result as well.
Do you accept referrals from healthcare, and does the county council pay for the surgeries in that case?
Well, you should answer that one.
Yeah, well, I think for a Swedish citizens with a Swedish citizenship, they are covered by the normal healthcare system. And so these surgeries are right now, I know Malmö has most experience where I've worked before. And I think in the March, April, the National Board of Health and Welfare will decide which hospitals in Sweden that are doing this procedure. So they might be at most 3 hospitals in Sweden that can do this, but Malmö has the largest experience with over 400 patients.
But you should also mention that there is a line for the operation in Malmö, and as of now, you even know how many patients about waiting, or?
I think now there is about 8-10 patients on the waiting list.
Yeah, and as of now, we can't. We don't have a possibility to have referrals from the regional clinic hospitals in Sweden because they don't, as of now, they don't pay for the treatment here in our clinic, Aleris. Yeah.
But it might be that it will change in the future because the number of beds in the last 20 years have decreased considerably. I know when I started in Malmö, we have 40 beds for adults. Now there is only 7-8 beds. And the operation slots, we had 3 rooms every day, Monday to Friday. Now there is about 1/4 of that today. So, and in some instances, for example, a typical, if the patient fulfills criteria for breast reduction or abdominoplasty after weight loss, these patients were operated only at the plastic surgery units, but due to the decrease of the beds and also the operation slots, many of these patients are now going through the separate regions out to the private hospitals, and the regions are paid for that. That goes for abdominoplasties and breast reductions, but maybe in the future, if something that doesn't happen with the amount of beds and so forth, also private clinics could do lymphedema, but not for now.
Yeah.
Then a question, what about exercise? Is it okay with hard, fast running, or should I take it slow and only walk? I got the lymphedema in one leg.
Well, actually, there has been many reports from the team in Lund, physiotherapists who have looked into this, cold walking, and what can be shown there is that the edema increases a little when you have strenuous activities, but then it goes back again. So that has been shown. So actually, exercises are, we tell the patient that there is no restriction on exercises. We had one patient in Malmö who were doing these camp things that they pulled a lot of weight on a rope and went through the woods. And so actually, when you have the garment, that is your safety belt. So carry on with the exercises, but take a step back when you feel that you have reached your limit.
Does the cost of the operation vary depend on the volume or limb?
No, one size, one payment. I mean, if
Yeah,
it's 7-8 liters or 2 liters, it's the same cost.
It's different. It's a little bit less for arm than for leg.
Yeah, that's right.
Leg is a little bit more, or yeah, it's more, and the arm is it's easier. It's faster to treat the arm.
Yeah, it takes much shorter time.
If I had a car injury on the right leg above the ankle, and now 6 years later have swelling in both halves, could it be lymphedema, or should it be in one leg and in the whole leg, or should it only be below the injury? I have no swelling in the feet, thighs, and barely any in ankles.
Well, normally, if you have a trauma to the leg below the knees, like the lower limbs, and there has been like a compound fracture or open fractures, you can have a problem with the lymphatics. But since your feet are not swollen, I doubt that it's lymphedema. But you can always ask your GP to send a referral for lymphoscintigraphy if you are in doubt. And also this stemmer sign in your feet since they are not swollen, would be negative. So if you are in doubt, do a lymphoscintigraphy.
I have primary lymphedema in my left arm and both legs. Would you treat the arm first, or would this be discussed at the assessment appointment?
Yes, that could be assessed, and if we see the patient here, of course. But normally, if you have both legs and one arm, it's normally a genetic trait. So normally your doctor at home should do a genetic testing. This is quite rare, I would say.
I agree. Yeah.
How can you tell if you have lymphedema or lipedema?
Well, again, we had this pitting discussion before, and lipedema does not have a problem with the pitting. So you don't have the volume, the fluid. Yes, you can have some kind of experience that your leg is getting bigger in the afternoon, but it's you don't see the pitting. You don't see the stemmer sign on the foot. So it's a big difference between lipedema and lymphedema.
And also, I would emphasize that there is no edema in lipedema. This goes back to a publication in 1940 by Ellen and Heinz, and they described the disease lipedema, which I think is a melanoma. It should be lipalgia syndrome. These patients that were described were sitting a lot, they were overweight and had difficulty in walking. And then you have what you call a static lymphedema, or edema due to that you're not moving your legs and compress the muscles in the calves to promote the lymph transport. So anybody who is sitting on a 10-hour flight across the Pacific will feel that after the flight, it's difficult to put on the shoes again, because everybody gets swollen if you just sit for 10 hours. But there is no edema in lipedema. That is a misnomer that is going to be changed in the future.
The doctors, two different, have said it isn't lymphedema. They said it's normal, but I am very worried.
I didn't get that. You think you have a lymphedema, but the doctor says not lymphedema.
It's normal, but I'm worried.
Well, if you're worried and you have signs of pitting, when you press as hard as possible with your thumb on the lower leg below the knee, between the knee and the ankles, just where the skin is just tight on the bone, and you get 10 millimeters of pitting, then you have a lymphedema. And in doubt, you can ask the physician, your GP, to make a lymphoscintigraphy. In patients with lipedema, the lymphoscintigraphy is always normal, if they don't have a BMI up to 50.
If it is genetic lymphedema, can you still have liposuction?
Yes, because primary lymphedema are all genetic.
More questions?
No, I think that was all. Maybe someone can with more questions.
Yeah, maybe if there are more questions, we can just answer them on the homepage and carry on with that.
So if there is,
we got one more question here.
okay. I've had arthrosis in both knees, and I don't lose weight.
Yeah, there is. I think it said that there is no operation because the BMI is 41, and because the limit for doing liposuction on a lymphedema is 30. And for legs, for example, if you have a leg that is 5 liters, we deduct 5 kilograms from your weight before we calculate the BMI. And the reason for not operating above 30 is that it's much more difficult for the patient in the postoperative period, and it takes much longer time. And also, just generally, when you have a high BMI, there are other risks with surgery that has been shown for any kind of surgery. And I think also that when you do surgery for arthrosis in the hips or knees, the orthopedic surgeons also has a BMI and wants a patient with a normal or maybe up to 30, not more.
And we have one more question now also. It's a follow-up on the car injury question. Should I be worried and work prevention, or should I conclude it's nothing to worry about since 2 doctors have said it's fine and normal swelling? Or could it develop to lymphedema? I have no pitting, but it's scarred. It's in early stage.
Okay, so you need a diagnosis, and since you have been asking 2 physicians about this and you're still not confident with what they have said, I think you should ask them to have a lymphoscintigraphy to rule out. But if you have a lot of scarring tissue above the scar, it can bulge a little because maybe they have put skin grafts on due to the trauma and maybe an open fracture. But without seeing you, it's not possible to have a definitive answer. You have to have a diagnosis, and that has to be ruled out by lymphoscintigraphy, for example.
Yeah, but still the major treatment in this case, it's compression.
Yes.
So if you don't get this lymphoscintigraphy, it would be a good treatment to get some kind of compression garments, because this can this prevents even if it's not a lymphedema, you will still have a good result with compression. So start with compression and then ask for lymphoskin.
On the other hand, if there is no pitting, there is no edema, and then you don't need any compression.
Okay, but I still would argue for the compression garments because it's post-operatively, and if you have the scarring tissue, it's a good way to treat this.
Yeah, I want to see the patient.
Okay.
And I want to scintigraphy.
Okay. Yeah, perhaps we can conclude.
Yeah, one more question.
One more.
Does chronic lymphedema pit?
Yes, all untreated lymphedemas have pitting. And you have to, I've had people in Malmö coming in and I ask them, do the pitting test. And they just do like this for a few seconds. Oh, there is no pitting. And then I press with my 90 kilograms staying at the feet, and I put all what I can, the pressure, and in 2 minutes, I have 1.5 centimeter. So chronic lymphedema untreated can be very stiff, and you really have to do the pitting test in the right way.
Okay. We thank you all for this.
Yeah.
Thank you, Professor Brorson, for this, and I hope you have learned a little bit. And of course, if there are more questions, you can always then send them to this email, info@artclinic.com, and we'll try to get back to you. Okay, thank you very much.
Bye for now.
Bye.